Welcome to The Explainer. Today we're going to tackle GI malignancies and build a really practical framework you can actually use. We're talking high-yield stuff for the wards, for your exams, basically everything from a patient's first symptom all the way through to long-term follow-up.
All right, so here's our game plan. We're going to walk through this just like you would with a real patient. We'll start with the big picture, then get into the nitty-gritty of the workup and treatment. After that, we'll touch on some of the super cool molecular stuff and wrap it all up with what you need to know about surveillance. Okay, first up, a primer. And to keep things focused, we're going to anchor ourselves with colorectal cancer. You know, it's the fourth most common cancer up here in North America, so if you can get a solid handle on CRC, you've honestly built a fantastic foundation for thinking about pretty much all the other GI cancers.
Now, this is something you absolutely need to be aware of because it's changing how we practice, like right now. Look at this. We are seeing a really notable rise in colorectal cancer in younger folks. Just a decade ago, it was about 10% of cases in people under 50. Today, it's up to 12%. And that is exactly why the screening guidelines have dropped the starting age to 45. This isn't just a statistic, it's a real-time shift in epidemiology.
So that brings us to the workup, from symptoms to staging. And let me tell you, once you suspect a cancer, these first steps, they are absolutely crucial. They basically set the stage for everything that comes next.
And this right here is such a classic clinical pearl. Where the tumor is located totally changes how the patient presents. Think about it. Left-sided tumors are in a narrower part of the colon, so they're way more likely to cause things like changes in bowel habits or even an outright obstruction. But right-sided tumors, they're in a much wider section, so they can grow silently for a long time, often showing up later with something way more subtle, like an iron deficiency anemia from a slow, hidden bleed.
Which brings up a really critical question, one you should definitely have an answer for. Why do right-sided tumors have a much worse prognosis? Is it just because they present later and more subtly, or is there something else at play here?
And the answer is, it's all about a markedly different biology. It's not just that they're found later. The truth is, tumors that come from the right side, which develops from the midgut, are just biologically different, and frankly, more aggressive than the ones on the left that come from the hindgut. You really have to think of them as two different diseases.
Okay, so once the cancer is confirmed, staging is next, and this part is non-negotiable. The foundation is always the TNM system. You'll need a baseline CEA level, a full colonoscopy, and then your imaging workhorse, a contrast-enhanced CT of the chest, abdomen, and pelvis. Oh, and here's a key exception to remember. For rectal cancer, you absolutely need a pelvic MRI. It gives you that extra precision for looking at local invasion, which is critical for planning.
All right, time for a super high-yield pearl. Knowing what not to order is just as important as knowing what to order. It can literally save your patient from a ton of unnecessary testing and anxiety. So, when should you actually avoid ordering a PET scan?
So remember this, for routine preoperative staging in CRC or for routine surveillance after treatment, don't order a PET. Same goes for staging and managing pancreatic cancer. The evidence is clear. A PET scan isn't better than a good old contrast CT for these specific situations. It can actually lead to false positives and a cascade of unnecessary procedures, so just stick to the standard of care.
Okay, so our patient is staged, we know what we're dealing with. Now we get to the fun part, the treatment approach. And you have to understand, modern cancer care is a total team sport. It's all about this coordinated, multimodal strategy, mixing and matching chemo, radiation, and surgery in really specific ways. And a perfect example of this is something called total neoadjuvant therapy, or TNT, for rectal cancer. The whole idea is to give all the chemo and radiation before the surgery. You hit the tumor hard up front. Now, this can shrink it down and make the surgery much cleaner. But here's the real game changer. If you get a complete clinical response, meaning the tumor seems to have vanished, you might be able to consider a watch-and-wait approach. That means potentially avoiding a huge, life-altering surgery altogether. It's a massive deal.
Now let's shift gears a bit. We're moving into the era of targeting tumors with precision. We're not just treating colon cancer anymore. We're treating a tumor that has a specific genetic fingerprint, and we have drugs that can target that fingerprint directly. This is the heart of molecular oncology.
And the first thing you have to get your head around is MMR, or mismatch repair deficiency. You'll also hear it called MSI, or microsatellite instability. They're basically the same thing.
Think of it like this. The cancer cell's DNA spell checker is broken. It can't fix its own mistakes, so it becomes hypermutable. Here's the key takeaway for you. Every single colorectal cancer needs to be screened for this. Why? Because if it's there, it opens the door to incredibly effective immunotherapies.
But wait, there's more. If you find a dMMR tumor, you're not done. You have to ask the next question. Could this be Lynch syndrome? About 20% of the time it is, and that's a huge deal because Lynch is a genetic condition. It's inherited. So it doesn't just affect your patient, it has massive implications for their entire family. That finding absolutely has to trigger a referral to genetic counseling, no exceptions.
Now, for any patient with metastatic CRC, this panel of molecular tests is not optional, it's essential. You need to know their CRAS, NRS, BRAF, and their MSI status. This information directly tells you which targeted drugs you can use and, just as importantly, which ones you can't.
So here's the bottom line. Think of these as exclusionary markers. If you find a mutation in KRAS, NRAS, or BRAF, it's a red flag. It tells you the tumor is going to be resistant to a whole class of drugs, the anti-EGFR therapies, like cetuximab. And knowing that is critical. It stops you from giving a patient an expensive, potentially toxic drug that just isn't going to work.
All right, we're in the home stretch now. Let's talk high-yield surveillance pearls. Your patient made it through treatment, which is amazing, but the journey isn't over. Now it's all about the long game, keeping a close eye out for any recurrence and catching it as early as humanly possible.
So this is basically your cheat sheet for surveillance after surgery. You've got a few things to track. First, you're going to see them for a history and physical and check their CEA level every 6 months or so for up to 5 years. Then you'll get a full CT of the chest, abdomen, and pelvis once a year, again for up to 5 years. And finally, the colonoscopy schedule. 1 year after their operation, then 3 years after that, and then it's every 5 years from then on.
So why all this work? Why be so intense about surveillance? Well, it all comes down to this number, 25%. Because even if the cancer comes back and spreads to the liver or the lungs, if we catch it early, when it's just a few isolated spots, we can still go in and surgically remove those metastases. And in up to a quarter of those patients, that surgery can still be curative. That's a 1 in 4 shot at a cure that we would completely miss if we weren't looking. It's a huge deal.
And that brings us right back to where we started, and to the single most important takeaway of this whole explainer: staging. It is the most accurate prognostic indicator we have, and it dictates the entire therapeutic strategy. Everything else we talked about, the fancy treatments, the targeted therapies, the surveillance schedules, all of it depends on getting that initial workup right. Getting it right from the jump is the most critical thing you can do for your patient. It really sets the course for their entire journey.